How's it going, everyone? Thanks for joining us today for this very important Facebook Live event. Today at Medscape, we're going to be talking about antibiotic stewardship, what it is, why it matters, and why all of us should be paying attention to this. My name is Dr. Alok Patel. I'm a pediatrician here in New York with Medscape, and I am joined by two physicians that are more skilled at this topic than I am and are smarter than me. Dr. Laurie Hicks of the CDC and Dr. Nicholas Jeans of Mount Sinai. Could you guys just give yourself a quick introduction for our audience real quick?
Sure, Alok. I'm Dr. Laurie Hicks. I'm the director of the Office of Antibiotic Stewardship at the Centers for Disease Control and Prevention, and I also have a background in infectious diseases.
And I'm an emergency physician at Mount Sinai Hospital. I'm also a clinical informaticist, so I help run our electronic medical records system across the Mount Sinai emergency departments.
So this is what I mean by both of you have more expertise and are more skilled at this topic than I'm ever going to be. But let's start off the bat. So when we talk about antibiotic resistance, I don't think that's a topic that many people are foreign to. People hear antibiotics, overprescription, overuse, and anyone can understand that that's an issue. But antibiotic stewardship, I feel like that phrase is a little bit foreign. Could you guys go ahead and just give us a kind of an overview of what that means?
Sure. So I'll start off by saying that the point of antibiotic stewardship is that we want to make sure that patients only get antibiotics when they need them, and when they need them, that they get the right dose, duration, and the right drug. And the point of antibiotic stewardship is to improve the quality of patient care to make sure that the patient is getting the best treatment for their illness.
And you can really think of antibiotic stewardship as a subset of just good prescribing habits, whether we're talking about following guidelines for opioids or other pain medications, really just getting the right drug to the right patient in the right setting.
See, I think that's clutch, what you were saying, because when it comes to opiates, we commonly think about duration, dose, is it IV, is it PO, how long are patients on it? And I feel like with antibiotics, we're commonly thinking, is this the right antibiotic? But we forget about duration and dose. So my question is why is antibiotic stewardship important? Like, why should every hospital have an antibiotic stewardship program?
So we think that antibiotic stewardship is paramount because antibiotic stewardship is really important for preserving the life-saving benefits of antibiotics. So we know that antibiotics have really helped us save millions and millions of lives over the many decades that they have been available. But now we're losing the ability to treat very serious infections, and in particular we're seeing more and more antibiotic-resistant infections, both in hospitals and in the community. And we're running into a situation where some patients are not able to get treatment, or they get treatment that is much more toxic because we don't have the most recommended, or the first line recommended drugs are no longer working anymore. And the other issue is it's really an issue of patient safety. So one thing that I think that we've learned over the past couple of decades is that antibiotics are not harmless drugs. While they're life-saving, we have to remember that they are also associated with side effects, and in some cases, people can suffer very serious side effects like Clostridium difficile diarrhea.
C. diff is like one of my biggest nightmares, and I feel like nurses are so good at smelling it like down the hallway. But every time we put someone on broad spectrum antibiotics at the Children's Hospital, I always wonder, I'm like, are we giving this patient C. diff? And I don't know why it's not a bigger topic, but Nick, you're an ED doctor.
Yeah.
And so I'm guessing offhand, not trying to like set you up here, but I'm guessing you see some adverse drug reactions presenting to you from antibiotics.
All the time, from little rashes to diarrhea that's not C. diff to kidney failure. It's a real concern. And so when you're talking about antibiotics, I think that has to be part of the conversation.
And one of the things we've learned that recently we've done some work and we've assessed visits to emergency departments for adverse events. And the most common reason why a child goes to the emergency department for a drug-related adverse event is because they've taken an antibiotic. So it's way more common than we used to think it is. And I think decades ago we thought, well, these are miracle life-saving drugs, but we didn't really recognize the potential downsides. And so now we're really trying to get that message out there.
That's insane. Like, I don't think many people actually understand how many people come to the ED or see their primary care provider because of a drug-related reaction. I mean, I work in a hospital. We commonly see creatinines fly through the roof, and then we take a step back and say, oh my gosh, this patient's been on Vanco for a week. But you guys are saying that people see it in the outpatient setting, and then they're coming to EDs with that.
Exactly.
And C. diff, obviously, I mean, this is from the CDC website, is an urgent threat. Am I right?
Absolutely. We're seeing more and more C. difficile infections. Unfortunately, not only in the hospital setting. For a long time, we thought of C. diff as a problem that was unique to hospitals and nursing home patients. But now we're seeing it in the community as well. And so people who are young and healthy are now experiencing life-threatening C. difficile infections. And unfortunately, there are more and more stories about taking one dose of an antibiotic and dealing with a life-threatening infection, and in some cases, a truly fatal infection, which can be horrible, obviously, for
Especially
a family.
If it's preventable.
Yeah, it's completely preventable. And a lot of these infections, and C. diff, I think, is unique in that it's an infection that results from taking an antibiotic, right? But there are some other examples of that, and we're seeing more yeast infections and other types of infections that we think may be, secondary to taking antibiotics.
Wow. We're starting to get some questions coming in, and so for all of you watching or just tuning in, we are talking about antibiotic stewardship, resistance, and everything in between. So if you have questions, throw them in and we will get to them. One of the first questions I'm going to address in just a second because I want to set it up better. But when we talk about an antibiotic stewardship program, I would love to talk about all the scenarios, but first let's get into it. What does a hospital need to have in order to actually have a successful ASP?
And so one of the first things that we try to help facilities identify is leadership. And it's really critical to have leadership within your facility and also recognition within the leadership, whether it's the C-suite or your antibiotic stewardship program, that this is something that is very important. And without that support and also support for staff time, it is very hard to get a stewardship program off the ground. Now, we're making a lot of progress in this space. More and more hospitals have stewardship programs. CDC has a framework for stewardship called the core elements, and we're seeing that increasingly each year hospitals are complying with those core elements.
Go to the cdc.gov and download that checklist, by the way. It's pretty awesome. Nick, you were going to say something.
I mean, part of the reason I think you're getting the adoption that you're seeing is now the Joint Commission is looking for this. And while the Joint Commission is, I think a lot of clinicians have mixed feelings about it, this is a simple and easy thing on their checklist that hospitals can implement, and it will do patients a lot of good.
Totally. So one of our first questions that came in, which kind of goes to this topic, so Jenna asks, how do you start an antibiotic stewardship program in a small community without an ID specialist? I think this is a pretty important question because when I'm looking at the checklist and I see one of those big things as drug expertise, so we have an infectious disease doctor like yourself, Laurie, and maybe a clinical pharmacist, people that really understand what drugs should be given at what time, some that we can cross-reference without going to UpToDate. So you're in a small town community setting, and you do not want to be negligent with your antibiotic use. What do you do if you don't have ID support?
It's a super question and incredibly important. And one thing I would just say is that we believe that stewardship in these small and critical access hospitals is just as important as it is in a large tertiary care academic center. And what we've learned is that there are distinct challenges for these facilities in terms of having the adequate resources to support a stewardship program. And so we developed a new set of core elements intended for small and critical access hospitals. But what I would say is the model may be a little bit different. You may not have an infectious disease trained pharmacist who can help lead the program. You may not have an infectious disease physician who can help lead the program. In a lot of the smaller settings, it may be a hospitalist. It may be a different type of provider who's taking that leadership role in that setting in terms of getting the program off the ground. Also, it's often reasonable for these facilities to reach out to other larger facilities and ask for help and ask for resources. There's there's kind of this new burgeoning area called telestewardship. And so a lot of facilities,
Fancy.
yeah, in the day of this tech age, there's a lot of facilities reaching out to other facilities that have the resources or have very robust stewardship programs, and they're asking for help from those facilities to enforce and reinforce their stewardship activities. And the issue is don't try to do too many things at once.
Yeah.
Identify the low-hanging fruit in terms of where you need to improve antibiotic use in your facility and start there. And so that's what we're recommending is identify expertise. It doesn't always have to be an ID physician or an ID trained pharmacist. Identify your champion and go from there.
Awesome. And Nick, you're designing a community hospital. I'm putting you in North Dakota. And your number one priority there is that this place is going to have a stewardship program. What are your top 3 priorities?
Well, you're going to be engaging those frontline providers anyway, whether they're in the emergency department or the hospitalists. So even if there's no infectious disease specialist, every hospital's got a pharmacist. Almost every hospital now has an electronic medical record system. And so you can leverage those strengths. And those are, the IT department there is in charge of the pop-ups and the decision support tools and the interactions and the drug testing and the allergy checking and so forth. You can use that to your advantage as you're setting up your stewardship program. And even the discharge instructions, one of the most visible aspects of the stewardship programs are that every patient that's getting antibiotics has specialized discharge instructions about how to take them appropriately.
Yes, and those discharge instructions are segueing me to some of the questions that are coming in. So we had a question earlier about what kind of adverse events that we see. Amy wrote in and said, what adverse events do we commonly see in the ER? So could you comment on some of the more common adverse events that you see and what we can do to prevent those?
Well, I think rash is probably number one, and it's whether we're prescribing Bactrim. There's a number of antibiotics, azithromycin and amoxicillin, all cause characteristic rashes. And it's regrettable sometimes when you're reviewing the case with the patient and you're not exactly sure if they ever needed the antibiotics in the first place, and now they're dealing with these complications. A lot of it is probably even subclinical. They're just feeling lousy, they're having diarrhea or yeast infection, but they don't choose to seek treatment. But the cases that really stay with me are the ones where they just happen to incidentally catch renal failure. And patient just happens to get a blood test and they're not making urine anymore and they're rushed in and they're hooked up to dialysis.
So actually, I started to interject, but Beatrice is actually asking, are there any outpatient recommendations for screening for end-stage renal disease? Or is there something that people should be doing or thinking about if they're taking a medication? They hop online, everybody Googles now, and they see that one of the side effects is renal failure. So going back to Beatrice's question, what should these patients be thinking about?
So my recommendation, especially when you're first receiving an antibiotic, is really try to generate that dialogue with your healthcare provider about what the possible risks are. We've done some formative research with patients and providers about adverse events, and what was really striking is that patients have really rarely had those conversations with their providers, because the types of adverse events or the types of side effects you might experience are different with different drugs. So depending upon the type of drug that you are prescribed, it is really a good question to ask your provider, what should I be looking out for with this particular drug? Should I be concerned about renal failure? Should I be concerned about C. difficile? Are there things that I should be looking out for that maybe I've never experienced in the past, but maybe I should be looking out for with this particular drug?
Absolutely.
Yeah. And sometimes we'll never be able to attribute the consequence of the antibiotics to the actual prescription, because like we were talking about before the show, Cipro causes these tendon, ligament ruptures, Achilles, all kinds of problems, and that can happen months later. So it's hard to sometimes pin it down, but these risks are out there. That's why they have the black box warning.
It's like those little lines that we learn when we're studying for Step 1 in med school. They come back to bite us later.
Yeah.
Remember, anyone that's chiming in right now, we're talking about antibiotic stewardship, resistance, the use. You guys can comment on, you can make fun of me, do whatever you want, but leave a question, comment, and if you have more questions about antibiotics, check out cdc.gov/antibiotic use for more info. But chime in, we want to hear your questions. So Marissa asks a really interesting question. Do probiotics assist in preventing antibiotic-related complications? I mean, I'm thinking already probiotics really popular right now, especially when it comes to gut health. We commonly give it to kids in the children's hospital, but what are your guys' thoughts on if it actually works?
So the research on this topic is starting to really pick up, and there's obviously a lot of interest. There are lots of products when you go to the grocery store. It's really overwhelming, right?
Yeah, I can't even go to Whole Foods anymore.
You can't decide what might be worthwhile or not. So what I recommend is, right now I think there are a lot of questions about probiotics, and there are many different types of probiotics, and we're still learning which ones might have the most benefit. So we don't know yet. The benefits are still pretty hypothetical. Having said that, when you're prescribed an antibiotic for a pneumonia or some sort of respiratory illness, and you're not really sure what you can do to protect yourself, my recommendation, this is more to my family and friends, when they ask me.
That means it's really, really important advice, by the way, if you're giving it to your family and friends.
This is the kind of, and this is what I do for me, for myself, and for my son. I go to the grocery store, I pick up some yogurt, and I eat yogurt because I feel like it's a relatively healthy food. We don't know that there's probably no harm in eating yogurt, but maybe there's a potential benefit. So that is kind of the practical advice that I would say that I am using right now. But there's a lot more to learn on this subject. I'm hoping that we find some solutions to preventing the GI side effects that we see with antibiotics.
Absolutely.
Yeah. I went into emergency medicine to avoid questions like this, but the truth is, I think you're right. I don't think there's yet guidelines or a meta-analysis out there that's saying when you're prescribing this antibiotic in this setting, you should give a probiotic. If there was, we'd have a pop-up for it. We'd have a little dialog box that would come up in the electronic health record and say, you ought to prescribe these two things together. And yogurt, I don't think is, it's still over the counter only, right? Yeah. So it's a great thing to recommend to patients, but I don't think it's risen yet to the level of a prescription. Yeah.
I'm glad, by the way, we're talking about gut health. And Jonathan, who's commenting right now, you're my hero, because this is a topic that actually drives me insane. So Jonathan comments about the dangers of taking Cipro. How serendipitous is that?
Yes.
So one of the things that drives me insane, and I want to get your guys' expert opinion on this, is people taking Cipro when they travel. And they say, last week we went to Southeast Asia, I had some bad pho, my stomach felt weird, I popped a couple Cipro. Can you guys just please unveil this big issue and just tell me what your thoughts are?
So there are a number of issues with that. First of all, we know that there's a potential risk with any antibiotic, but what we have learned more recently is that there are certain types of adverse events that are unique to the fluoroquinolones, and Cipro is one of the fluoroquinolones, which resulted in the FDA warning recently to not use Cipro.
Thank you.
and not to say not use Cipro ever, because it still has an important role for some infections. But we should be using Cipro very thoughtfully and only for the situations where it's absolutely needed. The other issue with using Cipro for traveler's diarrhea, and again, this is not my area of expertise, but what I would say is that we're seeing more and more resistance to Cipro among the common types of infections that we see in travelers. So it's actually, we're at this turning point where we really need to be reconsidering the recommendations around the types of therapies we are recommending for patients who are traveling. So I could talk all day about why we need to change our practices around use of the broad spectrum drugs like Cipro. I could talk about the piece of how we're using a lot of fluoroquinolones for non-specific respiratory infections, which actually don't require antibiotics at all. And then we're setting ourselves up for potential Achilles tendon rupture, which you mentioned, and neurologic problems, as well as other potential side effects. And C. difficile is a big problem with the fluoroquinolones as well.
Yeah.
Smelly C. diff.
Yeah.
Nick.
Yep.
But if you want to go down the rabbit hole, online there are communities, support groups where patients have gotten together and they feel like they're not the same anymore after they took Cipro, like behavioral changes, moods and thoughts changes that persist weeks and months after they take it. So there's a reason there's a black box warning on it. And so when I hear about people just popping a few kind of just prophylactically before a trip, it kind of, it's frustrating.
I'm sure you guys have both had friends that have been traveling and been like, hey, can you call me a script for Cipro? Anyway, let's just take it one step back to and talk about some of the situations in which people are prescribing. Now, Jean-Yves, I should be able to pronounce your name better because my stepdad is French, but Jean-Yves asks, are we seeing interns that are not as well versed in antibiotic use or how to use them in chronically ill patients? And I think it's an extremely important question, and it also segues us into talking about situations in which antibiotics are not appropriately used, like in what kind of clinical scenarios. So I will tell you off the bat that within pediatrics, when we see upper respiratory infections, when we see bronchiolitis, when we see otitis media, when we see sinusitis, there, as you guys know, there are certain situations where I'm like, you don't need an antibiotic for that.
Yes.
I mean, I wish I could stamp on every single public bathroom, like viruses do not need antibiotics. But what are some scenarios that nationally we're seeing inappropriate antibiotic use?
Unfortunately, it's still very, very common, even though these messages have been out there for quite some time. We know that antibiotics are commonly prescribed for conditions such as nonspecific upper respiratory infections, otherwise AKA the common cold.
The common cold.
We also know that antibiotics are very commonly prescribed for acute uncomplicated bronchitis. And if you ask anyone out if you were to go walk out in the street here and ask folks if they think that they need antibiotics for bronchitis, I would bet you that the majority of them would say yes.
Absolutely.
And right now, when we analyze data looking at that specific syndrome, we find that at least 70% of patients who go to their doctor's office for that particular syndrome get an antibiotic, even though it's not necessary at all. So we have a lot of work to do still.
Yeah.
Those are the two that really are the situations where antibiotics are almost never indicated, but are often prescribed. There are other syndromes you mentioned, so sinusitis, otitis, pharyngitis, for which antibiotics are commonly prescribed. There are it's a little bit more nuanced because there are situations there where antibiotics may be indicated. So, for example, for group A streptococcal pharyngitis or strep throat.
Get a test, make sure, verify.
But the key is getting that test, right?
Yeah.
Because in order to justify that prescription, you really should have a positive test result.
Rather than just kind of throwing it out there. By the way, your idea about talking to people on the street, I'm going to pitch that to Jimmy Kimmel. That's hilarious. Nick, what kind of things in the ED are you seeing? What conditions do you see people are asking for antibiotics for?
I'm sure a lot of similar stuff. We have a lot of bronchitis, otitis, sinusitis, and you know what? I feel like we sometimes assume the patient is going to demand an antibiotic, but the truth is, they're seeking our expertise. And what's the phrase we've heard before? Like, before a patient wants to know what you know, they want to know what you feel, and that you're empathizing with them. So when I feel like there's going to be a situation where it might become, patient is insisting on antibiotics, I try to hear them out and listen and empathize, because some simple phrases like, gosh, that sounds really tough that you're dealing with these symptoms. That sounds really frustrating, or I'm sure you're very scared. Just putting something simple like that out there really makes a difference, and then sets the patient up to hear what you have to say about your expertise. And so when I can establish that kind of connection, and this is hard sometimes because it's the first time I'm meeting the patient.
Absolutely.
But just doing that up front sets the stage, and then we can actually do some shared decision making, and even before I can do a physical exam or before I can do a strep test, I'll say if this is negative, that's good news. That means that you're not going to require antibiotics. Or if the chest x-ray that I can do in the emergency department doesn't show an infiltrate on the x-ray, that's great news. That means we don't have to worry about pneumonia. We don't have to prescribe antibiotics. And, by kind of cluing them into your decision making, you're building a bond, and you're setting the stage so that when you're discharging them, they're not expecting that script.
That patient bond, that's highly important. Anyone that's chiming in right now, remember, comment, ask us questions, anything that's on your mind about antibiotic stewardship, resistance, overprescription, whatever you want to know. I've got experts here who will answer everything. Going back to your point before we go to our next question, I find that when I sometimes actually sit down with parents that are worried and they're like, hey, I can't get rid of my child's cough, give me an antibiotic. First thing I got to wonder is it because you can't sleep and you're irritated? But I think sometimes going through those adverse events, like you guys were mentioning, actually gets people to say, you know, let's not, you know, like fix the burn by like stabbing the, you know, don't create problems. That was a very, very harsh analogy, but don't fix a problem with another one. Angela asks a very interesting question, and it kind of gets to things that people accuse us of in medicine. So Angela asks, how do you deal with leadership who pushes you to keep prescribing? And I think it's an important question. I'll personally say that I don't experience leadership that pushes me to prescribe. I do see the almost like the temptation to just kind of put a Band-Aid on a problem and say, you're on broad spectrum antibiotics, you're good. But I think this also is an important question because it kind of moves us away from this reputation of being pill poppers. This entire Facebook Live event proves that we're not. So could you guys please comment for Angela so we know that we're working with our leadership?
Yeah, well, if I may, leadership is very tuned to patient satisfaction scores, and they want us to see patients quickly. But I've never experienced pressure to actually prescribe certain drugs. So I try to keep patient satisfaction scores high by actually doing what I was just talking about, engaging with the patient, building rapport, and cluing them into my understanding and the physical exam findings that I would use to prescribe antibiotics if they were indicated. So I think that helps. It might slow things down a little bit, and that can get me in hot water with leadership later. But I think it's important.
But I bet if I went to healthgrades.com, Nick Jeans would be like, psh. Anyway.
The other thing leadership is really focused on, though, is guideline adherence and quality reporting. So, and this ties into what you were talking about before in the hospital in North Dakota that wants to set up antibiotic stewardship. Never met a hospital administrator that wasn't interested in improving their public reporting and their quality reporting. And now there's a lot of incentive dollars from Medicare and other places that are tied to this. So if you offer to your hospital leadership and say, I would love to look at our prescribing practices, I'd like to help us reduce our antibiotic prescribing for acute bronchitis or for sinusitis, that's going to translate into incentive dollars from Medicare. And that's going to make a lot of leadership.
Laurie, can you comment a little bit more on how to specifically address leadership and being motivated?
I think it's tough. That's a really good question. One of the thoughts that I have is I think a lot of champions for stewardship and improving antibiotic use initially found that perhaps their leadership didn't understand the potential for benefit of antibiotic stewardship. And what has helped is that there's more and more data out there that shows that having stewardship programs, having robust stewardship programs, and most of the data is from the hospital setting, actually improves patient outcomes. And so when you have that kind of information to first show that patient outcomes are better, you have shorter hospital stays, the patient is more likely to get the appropriate treatment, and also the costs are reduced. And unfortunately, sometimes that is really the bottom line.
It's realistic.
In terms of what motivates leadership to get on board with an antibiotic stewardship activity or program. We have good data in hospital settings to indicate that costs are reduced if you have a highly functioning stewardship program. Now, we don't have those kinds of data yet in the outpatient or long-term care nursing home space, but we're working on it.
Yeah, the costs are important. I was actually, this is not a plug-in, but I was actually myself on cdc.gov researching this and looking at the millions of dollars that we spend on C. diff alone. So I can't even imagine how much money like the 18 other and resistant bugs are costing our healthcare system right now. Nicholas asks a question that is near and dear to my heart as a pediatrician. And Nicholas asks, how much should we respect empiric antibiotic treatment with respect to outpatient care? Before I dish this over to the wolves over here, I will tell you that there are a lot of times, and you know, physicians, we respect each other and we are always on the same team, but there are times when I really want to know the thought process when I see someone come in, and this just happened last week, and has kind of a rash, but nothing that I'm really concerned about, and they're given an empiric azithromycin just because. Or, you know, we've had someone come in and say, hey, you know, I got augmented for my child, and I said, what were they treating? And I really just asked the physician to give us something because I wanted to make sure we killed whatever was in there. So I gotta ask you guys, what are your thoughts on empiric antibiotic coverage when we don't actually have an identified organism, or we don't actually have the sensitivity, or we don't know what we're treating?
Unfortunately, in the outpatient space, when we're talking about a patient who's presenting to a doctor's office, an urgent care center, a retail clinic, the vast majority of the time we don't have microbiologic results to guide our treatment decisions.
Fair point.
And so I think that is one of the major challenges of making a diagnosis and also making decisions around antibiotic treatment in the outpatient setting. So the vast majority of outpatient antibiotic prescriptions are empiric. I think what the key is here is really identifying whether the patient meets criteria based upon the recommended treatment guidelines. And there are very clear-cut guidelines for sinusitis, otitis, other common infections for when the patient should, one, be tested if they have pharyngitis, for example, or if they have symptoms of a urinary tract infection, and then the recommendations for how to manage that patient based upon their symptoms, as well as whether or not you have access to a test. So unfortunately, the outpatient space is full of empiric therapy.
Yeah, and the ED as well. We will, if we have a life-threatening infection in front of us and the patient's going to get admitted, we'll send cultures, but we can't wait for those cultures to come back. We've got to start treatment. And when we're discharging them, same thing. The good news is we can leverage the strength of our electronic health records to monitor the patients that bounce back with treatment failures, to look at those culture results and the patterns of resistance that are emerging. And we're very fortunate to have a great team at Mount Sinai that is constantly adjusting our antibiogram to show us what resistant bugs are emerging in our community, and we're often changing what is first line for UTI or for strep throat or other things because of the strength of these culture results. They're all in the electronic health record.
And one of the reasons why I think there is so much antibiotic prescribing in the outpatient setting, first, we mentioned the patient satisfaction issue, and that's paramount. That's probably the biggest reason. But the second is diagnostic uncertainty, because we do not have all the tools at our disposal to make a very clear-cut diagnosis every single time. So it is fair for providers to be in that position of not knowing for sure what the patient has. Oftentimes, in a situation where the patient is not severely ill, they have an episode of sinusitis, this is the scenario where it is perfectly reasonable to watch and wait.
Yes, yes, those are like the magic words I was going to just throw in the air if no one said them. I totally agree. Speaking of watching and waiting, aside from in the pediatric space, aside from sinusitis, the 10-day mark, or aside from otitis media, bronchitis. And a lot of viewers right now are commenting about antibiotic use and bronchitis, which, number one, we need to get to. Number two, that reminds me that if you're watching and you have questions or comments, fire them at us. We'll do our best to get to them. But let's talk about bronchitis. We see it all the time, every winter. The majority of the times, we don't actually start with antibiotics in pediatrics. If it progresses to pneumonia, fortunately you have the clinical exam skills to find that without resulting to tests. That's a different point. But can you guys please comment a little bit about bronchitis, antibiotic use, yay or nay?
So in the patient who does not have underlying lung disease, and what I would consider acute uncomplicated bronchitis. So I'm gonna just use my mom as an example, because I think she's watching. Say Mrs. Hicks.
Hi, Mom. Hi, Miss Hicks.
Mrs. Hicks comes into the office. She thinks she has bronchitis, but really what the provider is a little worried about is whether or not she might have pneumonia. And the provider listens to her lungs and then tells her that he does not hear any sounds that indicate that she has pneumonia. So the good news is I don't hear anything on your exam that indicates that you have pneumonia. anything that would suggest that you need an antibiotic. And the bad news here is that antibiotics aren't going to help you. And in that scenario, what the provider should do, and really what the best option is for that particular patient, is to give them options for symptomatic therapy.
Yeah.
And then say, if you're not feeling better in X number of days, Mrs. Hicks, I want you to come back to see me, or give me a call and let me know how you're doing, and we'll go from there.
Yeah.
Yeah.
I like that. I like that.
It's you're right, and I think in addition to offering, I do think patients, they're not necessarily demanding antibiotics or insisting on it, but a lot of they don't want to leave empty-handed. And so another thing we don't realize is how overwhelming the aisles of a drugstore can be. The over-the-counter stuff, there's a ton of stuff out there. You don't know what's best or most appropriate or why.
All that yogurt.
Yeah.
Sorry, I had to. I'm sorry.
By giving some concrete recommendations for symptomatic relief, you're still doing the patients a big favor, and you're avoiding all these unpleasant side effects that could have them coming back with rash or diarrhea or worse. So yeah, another thing is it's a great opportunity. When I see a patient in the ED that's coming in with cough, can't sleep, it's often smoking related, and sometimes the patients are kind of like, how did you know I'm a smoker? It's because you're in the ED with a cough, like a lot of our patients. So I actually use that opportunity for smoking cessation counseling and to offer, patches or gum, anything besides antibiotics.
Right.
We can make a difference otherwise.
We're not pill poppers, thank you. We don't just dish it out. Amir asks a pretty important question also. If we're looking at antibiotics, Amir is asking if there's any evidence against doing a short course versus a long course. And what's interesting is when I look at antibiotics and I look up something and I see 5 to 7 days or 5 to 7 days for this scenario or 10 days, I feel like sometimes it's user dependent. What are your guys' thoughts on that? I tend to veer towards the shorter end and try to say, hey, I'm going to check in on you, and if it's not getting better by that, we need to reevaluate. But I'd love to get your guys' opinion on that.
There is a lot of discussion going on right now about this particular topic in the medical community and the community that's doing research on stewardship. And one of the questions is really, what is the optimal duration of therapy? And it probably is different depending upon the type of infection. There are very serious infections that require very long durations of therapy, 2, 4, 6 weeks of therapy. The majority of infections, however, the recommendations are much shorter. We don't have great data in many instances on what the ideal or optimal duration of therapy is for infection. However, there are some studies in pediatrics. We know that actually 10 days of therapy, based upon recent studies, have shown to be more effective than shorter durations. Having said that, we are seeing that, for example, in community-acquired pneumonia, which has the IDSA, or Infectious Disease Society of America, and American Thoracic Society have recommendations that recommend a minimum of 5 days for community-acquired pneumonia. However, the patients are receiving an average of closer to 10 days of therapy.
So we haven't translated that yet.
So we have not. I think at some point in the future, and we will eventually get there. We're not there yet because the studies aren't there to prove the safety of doing this. I think at some point we're going to get to a place where you treat the infection until the patient is better and then they stop the antibiotic. We don't know yet how safe that is. So
yeah, no, I'm waiting on those guidelines. I've heard the discussion and I've seen some evidence, but until we have formal recommendations or this is the appropriate course, I'm not going to be adjusting our order sets yet, but maybe that day will come soon.
Well, we could probably do this for another hour or two, as we've demonstrated right now, because I haven't even cracked everything that we could ask about. But I really appreciate everyone tuning in and listening to us talk about antibiotic stewardship and why it's important. And if your hospital doesn't have one, hopefully Laurie and Nick gave you some ideas about how you can approach that. It's really important for all of us to talk to leadership, to see what we can do to be a little bit more mindful of our antibiotic use. And also, as someone commented, patients can be their own stewards. Patients can take action. And if you guys want to know more about antibiotic stewardship, you can go to Medscape. You can also go to cdc.gov/antibiotic use. Thank you guys so much for tuning in. We have had a great discussion here. We've covered a lot of topics, and we want to empower physicians. We want an open dialogue. So keep commenting, keep asking questions, and closing thoughts from Laurie and Nicholas, please.
Well, I think what you said about everyone can be a steward is absolutely the message that I would like to share. So whether you're a primary care physician, a nurse practitioner, a pharmacist, a patient,
Yeah.
we all have a role to play in improving